All right, well, welcome everybody. Great to see everyone. Um, Thank you for joining. We are poster session 11. So the theme is understanding and treating anxiety and mood disorders. And we have an absolutely fabulous lineup of presentations coming your way, which is fantastic. I want to welcome everybody. If you haven't yet shared, put into chat where you're joining us from. Fun to see some familiar faces and some new ones joining us today, which is fantastic. So we are going to have 6 different poster presentations. I'll ask presenters to share screen to show their poster and give about a 2-minute summary of kind of what their work was about. And then we want this to be as interactive as possible. People were awesome yesterday of just sort of jumping in with questions. And so after each poster, we'll try to save a couple of minutes for people to ask questions and open it up for discussion. Many people chose to share their contact information in the chat as well yesterday, which worked really well for people to be able to network and connect afterwards and all those kinds of things. So yeah, hopefully we can have some great discussion. So with that, I'm very happy to introduce our first poster presenter, which is Nayan. And Nayan, if you're on, can you let me know if I've got the pronunciation correct?
Yeah, that will be me for Nayan.
Oh, okay,
Yeah,
great.
and that is, I think that should be correct.
Okay,
Go
so
ahead and share.
Ben will be presenting on behalf of Nayan on their poster Game Pilot, investigating the clinical impact of a game-based digital therapeutic for social anxiety disorder, and happy to pass it over to you.
Awesome. So hello, everyone. I'm Ben with Arcade Therapeutics, and at Arcade, we develop therapeutic mobile games for mental illness that embed clinically validated cognitive training exercises for a range of therapeutic areas, including anxiety, depression, and addiction. Our technology is based on a decade of clinical research from our co-founder and chief science officer, Dr. Tracy Dennis-Tiwary, and our adaptive training algorithm couples mobile gaming mechanics with the cognitive intervention attention bias modification. ABM is a 30-year-old digital native cognitive training technique focused primarily on retraining attentional biases linked to mental illness through interactions with facial archetypes. So ABM is built specifically to target biases associated with persistent anxiety. Those with social anxiety disorder tend to focus more on negative or threatening information that can drive their anxiety symptoms, taking the form of worry, rumination, and dread. So this study consisted of 104 adult participants with clinically diagnosable levels of social anxiety and receiving usual care. Our primary endpoint was the Leibowitz Social Anxiety Scale. And one notable element of the study is that it included a gold standard, punishingly rigorous sham, in which the placebo arm included a near identical intervention, where users are promoted on a randomized basis towards both the positive and the negative stimuli, as opposed to just the positive. The results showed a significant differential between the arms, in which the active arm resulted in a 33% reduction in anxiety symptoms on average, which equates to a moderate effect size consistent with medication or CBT-based interventions. We also saw generalizability, with 68% seeing clinically meaningful benefit and over 90% seeing reductions overall. Patients in the active arm were over 3 times as likely to see meaningful benefits relative to the sham. We are excited by our FDA pilot trial's validation of our game ABM01 as an effective game-based treatment for social anxiety disorder, offering a low stigma, engaging intervention for patients. Thank you for your time.
Fantastic. Thank you, everyone. Really appreciate it. And for those who are just joining, let me encourage everyone to turn cameras on and we'll just have some conversation here. So Christine, you had a great question there. Interested in how this might translate to young folks, since I see this trial was done with adults. Are there plans for that, or yeah?
Yeah, so this trial, and through our process of going through FDA clearance, 18 and up is a much easier target because there's adverse effects for children they're nervous about. But we do have a wellness version of the app that is 13 and up. So definitely we see the teen, youth, college market as a really important subset of people struggling with anxiety that would really enjoy and benefit from a game-based approach to their treatment.
Fabulous. Other questions for Ben?
I know you reported on the outcomes in this poster. It was also very beautiful. I loved it. But in terms of engagement, because it's gamified, did you see better engagement over the course of the trial, or is that something that is also a struggle even when the app is very pretty and fun? Because I know that's something that we struggle with in our
Yeah, and
mental health?
engagement is certainly the name of the game for a lot of these approaches, and we hope that our unique method can help with that. Because this is a clinical trial and there's coordinators constantly messaging each participant and making sure they're staying on track, that engagement is a little higher than what we see naturally, but we certainly add game features and other sort of reward systems to try to get people coming back on the app as on their own and as naturally as possible.
Fantastic. Any last questions for Ben? All right, fantastic. Thanks for getting us started off so well. Do we have Alan on the line?
Yeah.
Okay, fantastic. Welcome to Alan, who's going to be talking to us about time-dependent changes in depressive symptoms among control participants in digital-based psychological intervention studies, a meta-analysis of randomized controlled trials. Take it away.
So can you all see my screen here? So yeah, I'm
Yes,
Tong from the Chinese University of Hong Kong. It's 12 o'clock in the midnight here, so hello to you all. So my topic is about time-dependent changes in depressive symptoms among the control participants in digital-based psychological intervention studies. I think we all agree that to this point, we have fairly huge number of studies showing the efficacy of online digital-based interventions. And these evidence are mostly derived from RCTs, as we all know. But the effect of control comparators in these RCTs have never been taken seriously. But actually, they represent important non-treatment specific effects and elements. For example, we try to recruit so many people into our trials, and they've got their expectation, they've got their motivation to join. And that's why we want to look at the estimate of these peripheral effects. So in our studies, we look at more than 100 RCTs concerning digital-based psychological interventions, with a total of more than 10,000 adults with depressive symptoms. And we try to find out the within subject effect sizes. The result is like that. We found that there is a small to moderate effect in reducing depressive symptoms within 8 weeks since the baseline assessment. And then afterwards, it keeps going down and then peaks at about 25 to 48 weeks, which we term it as the medium term. And then the reduction maintains to quite a flat level in the long run. So actually depressive symptoms generally reduce over time among these control groups. And of course, there's very high heterogeneity issues on to a need to document the procedures involved in these control groups. And nowadays we treat RCT design as gold standard, but what we found then is that the control group actually have fairly huge effects. So that is not the minimum requirement. We should always go for RCTs to find out what interventions are doing. And then researchers may also adopt like watchful waitings and other psychoeducation materials given to them to keep them in the line. So what we are trying to say that is that depression is not a never-changing condition, as we all know, and symptoms generally reduce within 48 weeks. But I would like to reiterate that this is not our goal to deny psychotherapy of any sort, but we want to empower individuals with depression to cope actively and not to lose their hope. So that's all of my presentation. Yep.
Fantastic. Thank you, Ellen. And thank you for joining us at midnight your time. You are a trooper for doing that. Appreciate it. Let's open it up for questions for Alan. I'm happy to get us started while others are thinking about theirs. This is super, super interesting, and I think raises lots of like challenging questions about what do we think about controls and how we manage that when we have conditions that tend to sort of remit on their own or have a waxing and waning kind of, temporal course. And I'm curious, one of the big challenges, obviously, if you're thinking about looking at depression is that there is high rates of relapse. So while there is that sort of tendency to have a given episode remit, people often have a recurrence. And so I'm curious, like, how that played out in your data, or whether you sort of saw that, or what you would expect if you tracked for another year. I'm just curious to hear your thoughts on that piece of it.
Yeah, this is always a challenge because there's not so many very long-term monitoring of data available. So most of the studies have 12 months of follow-up period, and then we do include here our period up to 48 months, which is beyond beyond even a year. So as we can see, the relapse is not so highly reported, but again, we want to say that it's not like, oh, depression is going to reduce and going down, you don't have to do anything. That's not our intention. But as we proceed to in the literature, there are so many interventions options and so many tools. And in our own experience, we also do RCTs, and very often of the time, we have a couple of studies in our drawer that doesn't have significant effects. But that really doesn't mean that the intervention is not effective. But then when we look at our control groups, we often give them, for example, psychoeducation groups. We have treatment as usual. We want to try to quantify these so-called the non-treatment specific effect. So that and as for your question for long-term relapse, even if we are trying to show people depression will go down, but they have to seek help anyway. They have to find time this period to find things that can be helpful. For example, self-help materials and things. Considering the culture in Hong Kong, Hong Kong have a very strange healthcare system. People have to wait for a very, very long time, say 1 year or 2 to get their first visit with the psychiatrist. And that's why we do this kind of research to show people, don't lose hope. You can try different things within this waiting period. And we do have a lot of tools that were put in the controls in these studies that you can also try, and they are also effective. That's the main reason why we are doing this.
No, that's fantastic. We have multiple questions in chat, which is absolutely wonderful. We'll take one of them now, and then Alan, I encourage you to respond in chat to the other questions that are coming up for you, but we'll make sure, and we can always circle back. But Melody asked about whether psychotherapy was the only treatment used in this study for the active conditions, or whether there was a variety of treatments.
We choose psychotherapy, including CBT, mindfulness-based. Those adhere to the common psychological principles. They are psychotherapies.
Great, thank you. Keep the questions coming, and I encourage people to, if we don't get to them all, then we'll circle back at the end, or people can answer in chat. Just in the interest of time, to make sure everyone gets a chance, I'm going to move us on and invite Danielle. Are you on?
Yeah, I'm here. I'm just going to share screen.
Great, and look forward to hearing from you on analyzing YouTube videos on suicide-related thoughts and behaviors, a study using topic modeling and discourse analysis.
Okay, can everybody see my screen?
Yes, you're good.
Okay, hi. Hello, everyone. Thank you. My name is Danielle. I'm a registered nurse and a PhD candidate at the University of Toronto and Center for Addiction and Mental Health. I have nothing to disclose. So we used a combination of topic modeling and discourse analysis looking at YouTube videos. We analyzed YouTube videos that talked about suicide-related thoughts and behaviors to identify what is being shared online. So using topic modeling, specifically the latent delusion allocation method, we analyzed over 500 videos. Then we identified 35 non-mutually exclusive topics. We then manually grouped these topics into 11 key themes, such as finding hope, addiction and substance use, relationship, near-death experiences. And keywords across all of these videos included life, talk, feel of, depression, and as you can see on figure 2. So then we next analyzed a selection of videos to understand the social meanings behind these 11 themes using discourse analysis, a specialized qualitative method grounded in post-structuralism. So through this analysis, we learned that individuals often express suicide-related thoughts and behaviors as a form of pain situated within medical context. We also found evident as mental health stigma. However, many were able to share survivorship experiences, resilience, coping strategies, such as seeking help and relying on religion. Our study findings provide insights to shape public health messaging to encourage help-seeking behaviors. However, we want to acknowledge that this study is limited to YouTube and lacks demographics data, which restricts the generalizability of our findings across diverse cultural backgrounds and other online platforms. So thank you, and let me know if you have any questions. Happy to answer them.
Fantastic. Absolutely fascinating research. Let me open it up for questions for Danielle. While people are gathering their thoughts, I'm curious whether you saw a difference in patterns when the YouTube videos were somebody with lived experience talking about kind of what they went through versus providers, healthcare professionals, researchers, etc., how differently those pieces played out.
Right. Thank you for that question. So as you can see on this figure 1, there were several video types, like you mentioned. There were 148 videos that had actual person sharing their own experience, whereas 126 videos were about interviewing family members or friends about their experience and talking about their daughter or son. And there were remaining 500 videos about news. So when we looked at qualitative, we did discourse analysis, we selected just a few videos that had rich, rich information about their experience. So we weren't able to see a lot of, didn't find patterns yet across these video types in terms of who shared their experience. But I assume that people, when person with lived experience share their experience, throughout these videos that we looked during discourse analysis, they often share quite sensitive information.
Mm-hmm.
And very surprised to the extent they share their personal experience online. So that was something that our team was surprised of, but we didn't see the pattern yet. This is still ongoing.
No, that's fantastic.
Study.
You have a pile of questions coming in here. So one question was if you could share contact information, which is great to connect with your lab.
Oh, yeah.
And Sharon also asked a really interesting question about, was it difficult to source videos for the analysis, as YouTube often censors sensitive topics? And would you imagine that videos that were not censored would be different in some way? Biased?
Right. So when gathering the videos, so we did like 6 inquiries. So what I mean by that is we use several keywords to find all relevant YouTube videos using YouTube's application processing interface. So it's like our program, I forget the name a bit. It's kind of like gathering all of the videos that are relevant to the keywords that I put. So then therefore that we need to go through the screening process, whether that met our eligibility criteria, like kind of like the scoping review or systematic review process in terms of screening methods. So it wasn't difficult to censor because I think when I did use API, it just generated all relevant videos, except I think different countries have different restrictions in terms of what is available to download. So that part I'm not too sure about.
Fantastic. There's a bunch of questions in chat that you can follow up on. We'll take one more quick one. Guest, do you have your hand raised? We'll just do one more quick question.
Okay.
Wait, I'm assuming that's me.
I think so.
I'm just curious. I'm sorry?
You're good. Go ahead.
Oh, yes. I was just curious if this was analyzing the video titles or like the comments that are included with the videos.
Oh, so we analyzed video transcripts. So we used titles and video descriptions to assess its eligibility, whether it can be included in our analysis. And then we did topic modeling of video transcripts. And then our subsequent phase of this project, we are looking at comments. But in this poster, we are the results are based on the video transcripts.
Great. Thank you for this rich discussion, and I'll encourage you to, all speakers have questions waiting for them in chat, so jump in as we continue this conversation. But that was fantastic. Thank you, Danielle. Very happy to turn it over to Taylor now, who's going to talk about pilot efficacy and target engagement of a cognitive bias modification for interpretation digital program for anxiety offered in a large healthcare system.
All right. Hi, everyone. My name is Taylor. I'm a PhD student at the University of Virginia, working with our wonderful moderator, Bethany. And this project was looking at the pilot efficacy and target engagement of our publicly available online digital mental health intervention called Mind Trails. And this is an online cognitive bias modification for interpretation intervention. And in this specific project, we were looking at a new dissemination pathway for this intervention. Specifically, we were trying to target folks that had either a diagnosis of anxiety or indication of elevated anxiety symptoms in their electronic health record, and then trying to invite those individuals to our intervention through the healthcare portal associated with that healthcare system. And this particular dissemination pathway afforded us the benefit of direct-to-consumer marketing with the sort of trustworthiness that provider backing can support, since it was distributed through the healthcare system, but it also didn't require any provider time. So we were curious to know if this was a feasible pathway for connecting folks to a digital mental health intervention. We invited 1,600 folks with anxiety through their healthcare portal to our intervention. Of those, 66 individuals started the intervention and comprised our intent to treat sample. And then we asked individuals to complete 5 sessions weekly through the online intervention and complete assessments of both negative and positive interpretation bias, as well as reports of their anxiety symptoms and depressive symptoms. Of those 66 individuals, 12 completed the whole intervention and comprised our per protocol sample. And we were interested in looking at corrected effect sizes for change in our target engagement, which is the negative and positive interpretation bias, as well as these more distal outcomes of change in anxiety and depressive symptoms. And we predicted that we would see at least small effect sizes in each of these outcome measures, with larger effect sizes for our per protocol group compared to the intent to treat group. Of note, this is a very white, non-Hispanic, and highly educated sample, with over 50% of folks having an advanced degree beyond a bachelor's degree. So it is not a very diverse or representative sample broadly, but it was representative of the patients of this particular healthcare system. In terms of our results, we did see changes in our measures of target engagement and the expected directions, with increases in positive interpretation bias from baseline to session 5, and decreases in negative interpretation bias from baseline to session 5. And we also saw changes in those more distal outcome measures of anxiety and depressive symptoms, with anxiety being measured through 2 separate outcome measures, the DAS anxiety scale and the OASIS. And then we saw small changes in depressive symptoms as well. And each of these things had small to large effect sizes, with most of these outcome measures having a larger effect size in our per protocol sample as we predicted. So this was really promising for the feasibility of this dissemination pathway, that when inviting folks to participate in a digital mental health intervention, sort of in addition to their healthcare through an actual healthcare system, brick and mortar style, that we can see these modifications to interpretation biases that may also be associated with more distal outcomes, changing those anxiety and depressive symptoms.
Great, thank you, Taylor. Let's open it up for questions. Feel free to just unmute or put them in chat. Great, looks like we have one come in from Ming Jing. Great presentation. Did you screen people for other medical conditions?
We have collected all of that information, but we didn't exclude anybody on the basis of comorbid conditions or previous treatment history. So interestingly, for this sample, I think it's about 70% of individuals were on some sort of medication for anxiety. So we didn't exclude them, but I do have all that information and am excited to look into how that might affect their response to this particular intervention.
Yeah, of course. Thank you. I'm just curious, like, I think there may be some other health conditions like infertility or like breast cancer that could contribute to like anxiety. Like, I'm curious about like how they may like response to this treatment.
That's a really good question. I don't believe we collected diagnostic codes for physical health conditions, only other mental health conditions. But that's a really interesting point that if they're seeking treatment with their practitioner for something other than mental health care, how might that be interacting with their anxiety symptoms?
Thank you.
Good questions.
I am curious how they access the platform, I guess, through the EHR.
Yeah, it's basically like a message through something like MyChart. So the intervention itself has its own website. You are invited to check it out here. And the particular link that they received just had like a code embedded in it so that we knew they were coming to us through this message from their electronic health record portal. But it was just like one of those messages that you can receive from your provider through something like MyChart.
Great. Any additional questions at this time? Fantastic. All right. Thank you so much, Taylor. I'm going to invite Megan to present next, who's going to be talking about reducing distress and hopelessness in youth with intrusive thoughts through a single session online intervention, preliminary findings.
Thank you. Can you guys see my screen okay? Okay, awesome.
Yes.
So, my name is Megan Sorority. I'm working with Claire, who's also a part of this meeting, and we're at Stony Brook University, and we're clinical psychology PhD students. So we are interested in studying intrusive thoughts, which are ego-dystonic thoughts, images, or impulses people have. So these thoughts are very common. They happen in about 90 to 93% of people at some point in one's lifetime. Some, though, are distressed when they have these thoughts, typically because they have a negative interpretation of what having these thoughts means for them as a person. So they might think it makes them a bad or moral person. They might not know how many others have these thoughts. They might not know the prevalence. And so the distress can be pretty impairing in their life. So we were interested in seeing if a brief single session intervention that lasts approximately 10 to 15 minutes and provides psychoeducation on what intrusive thoughts are, how common they are, and strategies that one can use to alleviate distress, if that could be helpful for young adults. And we targeted young adults. We're trying to target people who were having these thoughts and where these thoughts were novel for them. And we're also interested in seeing if this intervention could be helpful in adolescents too. So we have designed this single session intervention and we're testing the effectiveness in a pilot study. So far we've recruited 152 undergraduate participants. And so we've collected intrusive thought related distress data via the CY box, and hopelessness data via the Beck hopelessness scale. And we collected that data both pre and post the 10 to 15 minute intervention. And our aim was to see if such a brief intervention could reduce hopelessness and intrusive thought related distress. And we tested this via repeated measures ANOVA. And so far we have found that the intervention, which you'll see parts of on the right side of the screen, is effective in reducing intrusive thought related distress and reducing hopelessness significantly. And so we go from about a F score of a 5.3 to about a 3.66 in hopelessness and distress, about a 3.47 to 2.54. And we are trying to now test if this intervention would be effective when using other control conditions, and also what aspects of the intervention are most effective. And we're trying to get, like I said, clinical populations to test it and see if non-undergraduate populations could also have this alleviation in distress and hopelessness. But so far, the results are promising. And yeah, this is what we have so far. And on the right, you can just see slides that we created in Canva, just describing what intrusive thoughts are, because usually for the first time, this is people seeing the definition of intrusive thoughts and they find it very validating and meaningful for themselves. We talk about thought action fusion, which is that your thoughts are separate from the actions you do because of your thoughts. We talk about how entertaining the thought actually makes the intrusive thoughts happen more frequently. Like we related to scratching an itch, how scratching an itch just makes it worse. And then we invite people to talk about their own intrusive thoughts and share their own experiences so future participants can see what past participants found helpful in the intervention, and also can see the experiences of intrusive thoughts in past participants. And thank you. That's all I got so far.
Fantastic, really exciting work. Let's open it up for questions.
Yeah, I've seen some questions. So the post-intervention assessments are immediately after the person is finished with the intervention. This is done in Qualtrics. So they consent, they have the pre-intervention assessment, they then get to the intervention, they then get the post-intervention assessments. So it's typically within 30 minutes of taking the pre-intervention assessments, they do the post-intervention. And we're also conducting follow-up assessments 2 weeks after the intervention. We haven't analyzed that data yet so far. And yeah, so I see the question about shedding some light on examples of the items measuring intrusive thoughts. So right now we're mostly looking at OCD related intrusive thoughts, although intrusive thoughts is a very transdiagnostic construct. And we're allowing our participants to give examples of their own thoughts. And we're also providing multiple choice options for people to choose which intrusive thoughts they've had before, based off the ones that are very prevalent for young adults, like violent thoughts, repetitive thoughts, sexual thoughts, thoughts that their sexuality is not accurate, things of that nature. Yeah, I'd love to connect more with you, Catherine. That sounds great. And thank you for saying it sounds promising so far.
Yeah, super cool results. Megan, I'm curious how much you're thinking of this as a intervention when people are experiencing distress tied to their thoughts versus thinking about this as a prevention sort of opportunity for people before that they have those concerns, but are starting to have experiences of intrusive thoughts, because it's got that obviously the OCD prevention piece to it, but transdiagnostic as well.
Yeah, I would love to look into it as a more prevention aspect. I think my goal when initially establishing the intervention was to see if we could disseminate it to people who were just starting to experience these thoughts, who didn't know what they were, and so might not have an OCD diagnosis yet, and they're just questioning their own experiences. And this intervention could be helpful in just explaining what they're going through and just validating other people feel this way. So when looking at clinical populations, I think it would be really interesting to look at people who haven't been diagnosed with OCD yet. I think the next step is we want to see if it's helpful in people who are diagnosed with OCD, like, and are younger, and so maybe have more of a new diagnosis, and then prior to that can see if it would work as a prevention tactic as well.
Fantastic. Great. Any additional questions for Megan before we move on? All right, then I'm very happy to introduce Kayla, our final presenter, who's going to talk about mapping conflict escalation trajectories, coded behaviors, and physiological markers of romantic relationships.
Hi all, thanks so much for having me here today. A little bit about me. I am a clinical psychology doctoral student at University of Texas at Austin. And so I was working on this project and looking at how romantic couple conflicts occur naturally in daily life. And so we leveraged mobile technology where couples downloaded an app on their phone and it recorded them for 3 minutes. At 3-minute intervals throughout the whole entire day. And so we asked them to go about their everyday life, and we listened to the audio files and determined if there were conflicts. And then couples also on the phone completed different surveys where they answer questions about their mood every hour. So how angry or stressed were you? Did you have a conflict with your partner? And what we did was we matched the conflict data. So we determined if there were conflicts, and if there were, we selected one conflict per couple. And again, this is naturally occurring conflict. So one limitation is that they would be within that 3 minutes. And so we don't know how long, conflicts can last very long. So it's just a little snapshot. And so what we did is we matched it with second by second physiological data to see how conflicts, how electrodermal activity was changed over this time. And so our hypothesis was to see whether stress and anger before the conflict would increase reactivity and alter linkage in those conflict episodes. And so what we found was that couples showed in-phase physiological linkage when men reported high stress the hour before. So this means as female physiological response goes up, so does male. And then they showed anti-phase physiological linkage when men reported low stress. So we saw the opposites effects where as female physiological linkage went up, male physiological linkage went down. And then so we looked at the same thing with anger. So men who were angry before the conflict, both couples had in-phase physiological linkage. So men reported men had higher physiological response, and so did women at the same time. And then we saw the same things with low stress the hour before. And so now what we want to do for future studies is start listening. Well, so we've coded these audio files and looking at second by second behaviors such as anger, stress, or conflict intensity. And so future directions are going to look at these coded data and see how the coded data are related to this like moment to moment physiological linkage. And so we hope that it can help us understand these in the moment conflicts and how they occur naturally in everyday life, and hopefully eventually develop some interventions around that.
Fantastic. Thank you, Kayla. Super interesting work. You have a couple questions already in chat. First one is asking how you screened couples for the study. If you could talk more about that.
Yeah, of course. Yeah, so this was done over in Southern California area. And so we had advertisements throughout the community asking couples if they were interested in understanding everyday life. And so and so that's how we advertised for them. Mhm.
Great. Melody, did you have any follow-up that you wanted on the screening?
I'm good, thank you.
Okay, great. And then there was a question about,
Oh,
oh, go
mhm.
ahead.
Yeah, so that's a wonderful question. So EDA was selected over some other physiological markers because its latency is it's much smaller than other ones such as cortisol. So there's a 3 to 5 second latency. So we can see physiological responses quicker, and so versus cortisol can be much slower. And so and also we can measure EDA over the course of the day. So they wore wrist monitors, which collected EDA. And so we were able to collect that at a much smaller scale. But it would be really interesting to do a future study where you do EDA, where you measure EDA and look at other things like cortisol, and be able to look at, multiple physiological markers.
Can you talk a little bit about how you see these data being used for like just-in-time adaptive interventions? Because it seems, obviously lots of natural lead-ins to like, here's the time to intervene before it escalates.
Yeah, I think that's a wonderful question. I think it would be really interesting to see if can we understand how these physiological processes happen either before, during, or after the conflict, and maybe can we create markers that will help predict, like, okay, we think based on these factors, these variables, that conflict may happen. And so then prompting couples or people to say maybe do an activity where they can do some like mindful breathing, or and so I think it could be used because if you can detect a conflict before it starts, then it probably could help with like lowering the intensity, or having people be more aware of like, okay, actually I think conflict may happen. Like what strategies can we use to reduce conflicts or manage them better?
Yeah, absolutely. Other questions for Kayla? Great. Well, thank you so much for that presentation. We have a couple minutes left, just a couple, but were there other questions people didn't get to ask to any of our presenters that they want to have a chance to raise now? All right. Well, thank you so
Sorry,
much.
I had a question.
Yeah, please go ahead.
This was for the Mind Trail study. I was curious about, because I think you said you use CPT codes. Was that for all anxiety related CPT codes, or was it specifically for generalized anxiety disorder?
We extracted all anxiety disorder diagnostic codes from the electronic health record, and a very, very broad list of medications that they might have been prescribed for anxiety.
Okay, perfect. Thank you.
Other questions that came up for people? Wonderful. Well, thank you so much, everybody, for joining, and a huge thanks to our fabulous presenters. I love the variety of, they all fit under the theme, but huge variety of presentations today, and really, really exciting work. It makes me excited for where our field is going. So thank you all for joining. Enjoy a 10 or 15 minute break, and then we'll pick back up with a set of flash talks. Thanks all.